shoulder joint has the highest possible range of movements in the human body. This helps us in reaching objects all around us. To achieve this function, shoulder joint had evolved and adapted. When compared to a hip joint, which is also a deep ball and socket joint, the shoulder joint has a small flat cup, called glenoid, and a relatively big ball, the head of humerus. This arrangement biomechanically helps the shoulder to have great range of motion, but also makes it inherently unstable. The shoulder stability is provided mainly by strong ligaments called glenohumeral ligaments and the enclosing capsule. The glenoid socket is surrounded by a rim of thick fibrous tissue called labrum, which deepens the socket and the ligaments and capsule of shoulder attached to this labrum. The rotator cuff muscles around the shoulder joint provide compressive forces to ensure dynamic stability of the shoulder. Shoulder joint could dislocate due to trauma, pre-existing joint laxity, or rarely due to muscle coordination abnormalities. The shoulder typically dislocates to the front, when the arm is taken to the throwing position or when you fall on an outstretched hand. The capsule along with the labrum, the rim of glenoid, is torn away from the bone and the ball pops out. This tear is called the Bankert lesion. As the ball jumps over the glenoid, it injures the bony rim of the glenoid. In some instances there could be a significant glenoid rim fracture also. Once the ball dislocates, the sharp anterior rim of glenoid wedges into the back of the ball, producing a defect called Hill-Sachs lesion. Once the shoulder dislocates, the chances of recurrent dislocation is high, especially in younger age groups. Treatment includes identification of the patient type, the cause of dislocation, and identify the risk factors that dictate the success of the procedure, especially bone loss and poor capsular quality. In people without bone loss, who present early, the torn labrum is repaired through a keyhole procedure called arthroscopy. Using tiny cuts, the inside of the shoulder is visualized, and with precision instruments, the torn labrum along with the ligaments is reattached to the glenoid margin using tiny but strong suture anchors. Very fine 1.7 mm drill holes are made in the margin of the glenoid socket, and the sutures are inserted into the hole. After insertion, when pulled up, they bunch up and hold securely. One of the suture limb is taken through the labrum and knots are made to reattach the labrum to the bone. 3 to 4 suture anchors are inserted to ensure a secure repair. This is an arthroscopic view of repair with suture anchors. With repeated dislocations, the glenoid rim gets eroded, resulting in a glenoid bone loss, and the Hill-Sachs lesion gets deeper and wider, requiring only minimal rotations to get dislocated. Sleep dislocations also start to occur. When there is a significant critical bone loss, soft tissue repair alone will not be enough. These patients will require a mini-open procedure called Latarjet procedure, which builds up the bone and gives additional support to the soft tissue. Shoulder dislocation can be managed predictably, especially if one presents early. Critical assessment of bone loss is mandatory in each and every case. Patients with bone loss have to be managed by augmenting the bone.